Prashant, are we live?
Yes, sir, you are live. Go ahead.
Good evening, doctors, and good morning to Dr. Kabir Chaudhary, sir, as he is with his family in Canada. Myself, Shailendra Meena from FDC. I welcome you in this one-of-a-kind international symposium where doctors from Southeast Asian neighboring countries are here to share their experience. Dermatophytosis. It is not only an epidemic in India, but also in our neighboring countries, owing to topical climate and economic conditions of majority of population. FDC being the largest manufacturer of antifungal drugs in India, we have taken a step further to understand this problem of superficial mycosis, not only in India, but also in neighboring countries. Being on top, it becomes our responsibility to go to the crux of the problem and find out the solution. Today's event is a step towards that. We all need to come together with our capabilities, our experience, and our successful way of treatment. And all this data should be pooled and we reach to a conclusion. I hope this will help in finding out a solution in terms of policies, awareness, and practices, and medicine and its availability. Now, without taking much time, I would like to hand over the session to the eminent and most experienced dermatologist from India, who is going to introduce the topic for us, Professor Dr. D.G. Saple. Sir, over to you, sir. Sorry, I'll just give a brief introduction of him. Professor Dr. D.G. Saple is a fellow of Johns Hopkins University, Bloomberg. He is a retired honorable professor and head dermatology, venerology, and rheumatology department from Grant Medical College, Sir J.J. Hospital, Mumbai. He is pioneer researcher and clinician in HIV/AIDS in India, and he is first dermatologist in India to use fluconazole 150 mg daily dose in dermatophytosis. He is consultant dermatologist in Breach Candy Hospital, SL Raheja Hospital, and Fortis Hospital, Mumbai. He is also trainer for fellowship program in HIV/AIDS in IADVL. He was ex-president IADVL Maharashtra branch and ex-president College of Physicians and Surgeons, Mumbai. He was also examination for MD in various universities. He has delivered more than 1,001 lectures across country and represented the country at around 108 international events. He is ex-editor, board member, and IADBL textbook of dermatology. His list is numerous. He has 40 plus peer review publications and chapters in medical textbook and 55 papers presented in international conferences. And he has organized many conferences in STDs and AIDS. He has done international collaboration in academic research with Harvard School of Public Health, Johns Hopkins University, University of Yale, University of Toyama and Osaka, University of KwaZulu-Natal, and University of Roma, against many others. He has received a Lifetime Achievement Award from IMA and Lifetime Achievement Award from IADVL as well in 2018. And in 2019, he has received the Best Practitioner Award at Dermacon. And very recently in 2020, he has been honored as a member of IADVL Fellowship Derma. So, and his current research project is dermatophytosis. He's doing clinical research on that. With this, I'll hand over the session to Dr. Saple. Sir, over to you, sir.
Thank you, Shailendra. Can I have first slide, please?
Yes, sir.
No, the next one. Yeah. So good evening to everybody. That today what we are discussing is everybody's problem. This has become what we call the recalcitrant dermatosis. Dermatophytosis has become nightmare, not to the only dermatologists, but even to our patients. So this recalcitrant cutaneous mycosis is a major epidemic across all South Asian countries. Nuisance of widespread and failure of antifungal pharmacotherapy has become an ordeal. The discriminate use of steroids, whether it's a topical steroid or even systemic steroid, along with antifungal drugs, especially itraconazole, by OTC product, by the patient themselves, by the chemists, general practitioners, and doctors has indeed made the situation worse. Next slide, please. So we are dealing with a lot of problems. Then whatever the guidelines, whatever the mentioned conventional treatment in our books, guideline is mentioned by the Western countries are not enough to handle this problem or treat this what we call the recalcitrant dermatophytosis. And now most of our dermatologists also they do not know what to do. So with their own knowledge, with their experience, people are trying combination therapy. They are trying combination therapy. Hello, can you hear me?
Yes,
Yeah.
yes, yes,
Yes, sir.
yes.
Yeah,
Yes.
yeah, yeah. Yeah,
So
please
many,
carry on.
many dermatologists either they are trying the combination therapy, longer duration therapy, cyclic therapy, sequence. They are trying whatever they can feel is a better. And of course, that is the right approach. When you do not have proper guideline, we have to keep on trying your own experience. Next slide, Shailendra. Along with that, the major problems we are dealing with is the socio-economic problem. Most of our South Asian countries, we are not like Western countries where we can afford. We are dealing with masses or middle class where they are low socioeconomic. As being low socioeconomic, the people are living with a joint family, and when they remain with the joint family, the problem of multiple family members are affected. And when multiple family members are affected, it's like a ping pong infection that one person get all right, the other person pass on him. So, and with the today's effect of COVID-19, in fact, that is one is a health burden and second is the economic burden. And the cost of the drugs, everything is affecting common man so much. The cost has become very important factor in today's management. And of course, when multiple people are staying together, the hygiene is a problem. Next slide, please. So we do not know whether we are dealing with the resistance or dealing with the failure, what is called clinical failure. We do not know, so we call it a recalcitrant infections. It is lasts for longer time. Some people call recurrent. It occurs within 6 weeks. Some people call relapse if it is after 6 to 8 weeks. So there are a lot of problems, and these problems may be probably because the drug related. So we got to know what are the pharmacokinetics of drugs, whether the drug is reaching to the target tissue in a sufficient concentration or not is a very important. So that is the big issue is lying in front of us. That's why we have to keep on trying. And by trying, even we fail, I think that is the first steps of success. Next slide. Then there is a lacunae. For example, now we are talking about the steroids. At the same time, when you are using, most of us, we are using drug itraconazole. But at the same, like a steroid, most of our population, they are using antacid. And antacid, you know, the itraconazole is a weak-based formulation which needs the acidic pH. And if you are using antacid, I think most of us, if we do not give proper counseling, the patient may land up into what is called subtherapeutic doses. So the use of antacid in I think most of the countries is so rampant that physician has to take in the account before prescribing itraconazole about the antacid. Next one. So there are many problems. Then there are two sides of the azole. One, by the time patient comes to us, that is a dermatologist, 90% of the patient, they have taken multiple systemic and local antifungals. When they have taken the multiple antifungals, we do not know what dosage they have taken, whether they have followed the adherence, follow the compliance. We do not know. So probably we are dealing with the patients who are coming to our clinic. They have taken subtherapeutic concentrations of the drugs, and probably those are cases of failure. Next one. Then coming to about the research. Unfortunately, when you talk about the fungus, if you open any international research, there are a lot of research, thousands of research on Candida, because the Candida is a problem in the critical care. It can be fatal, it can be lethal. While dermatophytosis is not a big problem. So there are the hardly research on dermatophytosis compared to Candida. That's why in the Candida, they have found a lot of resistance. So we have to work whether we are really dealing with the clinical failure, suboptimal doses, or the low MIC, or it is true drug resistance. We got to do the research. And for this research, all of us, most of us who are attending, they're already teachers, they are experienced. So we must come together and get more involved in the research. We cannot depend on the research of the Western, because Western country. Yesterday I was discussed with Kabir Bedi, one of the panelists. He said there is hardly any problem in Canada or in USA. Next slide, please. Then about what are the emerging problems? About the emerging problem, that whatever the investigations or whatever the research we are doing, we have to do it together. Next slide, please. Yeah, so the big problem today that we need a drug. We have many antifungal drugs. We have griseofulvin, itraconazole, fluconazole, terbinafine, many. But we need ideal drug, which will be potent or effective drug, safe drug, cost effective, quality of the drug we can use for the long term, has minimum drug-drug interaction, convenient to take. There are many more characteristics. So we need this drug. And with my experience for last 2 years, I found fluconazole is one of the good drug, but that we are going to discuss in the during the discussion. Next slide, please. So now we have taken the torch like the Olympic torch. Now we have taken the torch for the treatment and the management of fungal disease. That is the torch of antifungal. So I'll request Dr. Kaushik, who is a moderator, to take this torch. First is the Southeast Asian countries, and then globally. That is our aim in the future. And before I thank you, I would like to introduce our moderator, Dr. Kaushik Lahari. Can I have a slide, please? Kaushik Lahari is a professor and senior consultant dermatology in Calcutta Apollo Glen Eagle Hospital. He is an honorary director and senior consultant dermatology in Wisdom. He is a vice president, International Society of Dermatology, editor emeritus, Indian Journal of Dermatology, past president, Association of Cutaneous Surgeons of India, fellow of Royal College of Physicians, Fellowship in London, Edinburgh, and Glasgow. I think this is a rare honor. He has finished all 3 places. Then he is a recipient of many awards. AD Member Making Difference Award in 2018, International Leagues of Dermatological Society ILDS in 2015. He has got many more awards. Without now wasting time, I'll hand over this mic to our moderator, Dr. Kaushik. Kaushik, please go ahead.
Thank you, sir. Thank you very much.
Yeah.
And thank you for your very kind introduction. And now, if I'm allowed to share my screen.
Yes, sir, please.
I think you can all see my screen.
Yeah, no problem. Yeah.
Yes, sir.
Thank you very much, and welcome to this what I call Dermatophyte. That is the Southeast Asian webinar, and I'm thankful to FDC for giving us the opportunity to share our thoughts and in this regard. And the topic today is dermatophytosis, an ordeal for dermatologists and patients alike. And to discuss these, we have four legends from our subcontinent. One is my friend, my dear Professor Anil Kumar Jha from Kathmandu, Nepal. I have used some different photos, Dr. Kazmi. So I downloaded, I had wonderful photos of you in my computer. So Dr. Atif Kazmi from Lahore, Pakistan, who I know for the last 20, 25 years. And also respected Professor Dr. DG Saple from Mumbai, India. And thank you very much for your kind introduction. And another very respectable senior person from this subcontinent, Professor Kabi Chaudhary of Dhaka, Bangladesh. But at this moment, he is here. You'll be astonished to know how many hundred and thousand dermatologists are seeing all across India, Bangladesh, Nepal, and Pakistan. Professor Kabir Chaudhary is joining us from the other hemisphere. He is there in Canada. So it's my proud privilege to introduce Professor Chaudhary. Kabir Chaudhary is regarded as internationally reputed leading dermatologist and pioneer skin and laser surgeon in Bangladesh. Brilliant academic and professional record, graduation from Dhaka Medical College in 1974, started his career as a medical teacher in 76 in Dhaka Medical College. And his specialty in dermatology and venereology, excellent grades and top of the list from University of Vienna, Austria. And undergone intensive training in Vienna, then in American Academy of Dermatopathologists, then skin laser surgery from Harvard, training in sexual medicine from University of British Columbia, Canada, and skin surgery from AIMS in Delhi. He was confirmed FSCP from Royal College of Glasgow, and we are from the same college. And he has a global work experience started from Abu Dhabi, Iran, St. Thomas Hospital, London, visiting professor, University of Ottawa, Canada, University of Mississippi Jackson, USA, faculty, Rita Skin Foundation, Kolkata. I was there with him in Rita. Present position is a founder, principal, professor, and head of the department as by the government body in MHS Medical College Hospital, chairman and chief consultant, National Medical Center, Dhaka. I have been to his wonderful National Skin Center in Dhaka. He is a personal dermatologist to the Honorable Prime Minister of Sheikh Hasina, Prime Minister of Bangladesh. Research paper, author, and co-author book of dermatology, dermatosurgery, and abuse of topical steroid. He is an author of my book as well. And also the brilliant dermatologist from Pakistan, respected Professor Dr. Syed Atif Asnain Kazmi, and HOD, King Edward's Medical University, Mayo Hospital, Lahore, Pakistan. Various positions held at King Edward's Medical University, Registrar, Member Syndicate, Member Senate, Chairman Investment Committee, Dean Faculty of Medicine, and I, Dean Committee of Medicine and Public Health, President, Pakistan Association of Dermatologists, 2011 and 12, General Secretary, Southeast Asian Regional Association of Dermatologists. So he is a widely known personality all over India. He is known, and I don't know how many national conferences of our country he has attended. And a member, Drug Regulatory Agency of Pakistan, author of 6 books, convener of PMRC, expert panel of dermatology, examiner of FCPS, MCPS, and FCPS, MD dermatology, member of AAD, European Academy of Dermatology, Asian Dermatology Association, 45 publication, 90 international and national conferences. And also, I have changed the photo, Anil. I like this photo very much.
Thank you.
He's a founder chairman, and we are from the same generation. Myself and Anil, we have long history of friendship. Founder chairman, DI Skin Health and Referral Center, DISHARC, Kathmandu, Nepal. Founding chairman, Community Health Education Service by Telehealth, one of the pioneers in this subcontinent, Chest, Nepal. Founding chairman, International Community of E-Health and Telehealth, ICEHAT. Life member of Society of Dermatologists, Venereologists, Dermatologists, Nepal. Founder secretary of Telemedicine Society. Member International Society of Dermatology. Editorial board. Member International Society Journal of Dermatology, Venereology, Institute of Dermatology, Chinese Academy of Medical Science. Published around 40 articles in national and international journals, more than 50 paper presentation, and I have witnessed his beautiful presentation in many international conferences. National Service Felicitation by Nepal Youth Society, Lifetime Achievement Felicitation by the Right Honorable President of the Nepal through the Society of Dermatologists, Venereologists, and Nephrologists, Nepal during the 6th SARC D and 7th Sodvelon conference. So these four gentlemen, you'll be surprised to know, they represent a huge number of dermatologists from this zone. And we, in between ourselves, we serve a staggering 1.8 billion people. That is 1/4 of mankind. If we consider 7.4 billion people all over the planet, we serve 1/4 of them. And coming to the subject proper, it is not a fun guy anymore. So how big is the problem? As per the WHO data, sometimes WHO, before this COVID scenario, they used to deal with other diseases which are non-COVID. So WHO told that it is about 25% globally. And how big is the problem? So if I ask my first question to all the panelists, how much of your daily patient load consists of superficial dermatophytosis? If I start from Dr. Kabir Chaudhary, sir.
Yes, in our country, we know because of the socioeconomic condition and because of the sanitation problem, etc. And in my own practice, every day, minimum I see 25% of my patients are dermatophytosis. And mainly they come from village, and also now urban people are having the same problem and becoming so big problem now. Family, grandfather,
So this is
father,
your experience in
everybody.
Dhaka. That is a metropolis mega,
This is the
very
Dhaka
big
city.
and that is 25%. I would like to know your experience, Professor Kazmi, your experience in Lahore. That's
Yeah,
also a very big city. What is your experience?
yeah. Basically, what I feel is I agree with Professor Kabir Chaudhary, and it all around 20 to 30% of my patients, clinical
Now that
in
is
my
also
private
huge.
practice as well as in the hospital where I work, they are suffering from various types of dermatophytosis.
So one
Now,
fourth of your
about 20 to 25% of the
yes.
total patients that we see are
Mhm.
having various types of dermatophytosis. So the main problem here is for dermatophytosis when the weather, hot, humid weather, it is ultimately sweating people, and especially when you see the people who are living in a poverty range, and those patients where the number of people in a family are more than 6 or 7, and obviously they're all cramped up in one room. So there we find a lot of
So we'll come to that. I just wanted to know the extent. I'll come to that.
yeah.
Dr. Sapley, what is the percentage you deal with? I know now in the COVID scenario, you are
Yeah,
homebound, but
yeah,
you are very, very popular among your patients.
Yeah.
What is your experience of just percentage wise? Very
yeah,
short
yeah,
time.
yeah. See what they're saying that our Indian also experienced the similar experience. Almost 25% they have got. Only thing what I observe, it has not remained only with the low socioeconomic group, but
That's
even
interesting.
the rich
Yes.
people, the problem is on the rise.
Yeah, yeah. So I know you have many rich patients, though that is also very, really, we all know that. And what about Dr. Anil Jha? Is it
Yeah,
same
dear
20%,
Kaushik,
30%, or you are seeing more?
in my practice is 20 to 30%
The
that I
same.
find. Yeah.
So I think we all agree. And very recently, sir, I came across this WHO study. Global prevalence 20-25% the same, and it's a total of 1 billion superficial fungal infection. Can you imagine? So that is 1 billion, that is 100 crore. We all understand crore in our subcontinent. They are suffering from superficial fungal infection. So what are the current challenges? If you just enumerate, any one of you can take up. I'll just open it. What are the current challenges? Very brief. One top. You just anyone can cite one point and another one just help with another point, but don't elaborate. What are the current
I think,
challenges you face?
actually, current challenge is main
Yes,
the
sir.
treatment failure.
Treatment
We are
failure.
giving medication, patient come back,
Yeah.
not completely relief, or they are having the disease, or somebody else coming from the family with the disease. So
Yeah.
this is the maybe recurrence, maybe relapse, maybe it is recalcitrant. This is the main challenge we are facing, even in
Anil.
children, even in
Yeah,
infants.
I understand, sir. Treatment failure. Anil.
Yeah, the recurrent relapse the contact histories, the family members having the similar problem,
Very big
and
problem.
the pediatric patient having increasing in number, having facial type, and also erythrodermic type of the
So I think you
dermatophytosis.
have finished all. And Kazmi Saab, what's your
Yeah,
experience for
I
intelligence?
personally feel that the resistant type of dermatophytosis, and especially the recalcitrant type, and those people who have been using steroids, they are having this problem in a large number. And those steroids which they use, they
Mhm.
are used at their own or provided by the coax. So I think that
You have pinned it. You have nailed the point. Absolutely, sir. I fully agree with you.
yeah,
Dr.
and
Saple, sir?
yeah.
Yeah, see, apart from this, the most important is now the disease is becoming the chronic. When the diseases become chronic, is the management we have to change according to the chronic
Fully agree.
disease.
Fully
Number
agree.
two, the counseling. Our most of the dermatologists, they do not have enough time for counseling. Number three, drug interaction. Many people are living long. So now whether they are on polypharmacy, so using drug, then counseling, adherence, compliance, and of course, use of steroid is a very important things. But what is and the changing clinical picture, that is a big problem in today's practice.
Thank you, sir. I'll just enumerate one by one. A treatment
Yeah.
failure, recurrent dermatophytosis, relapse, chronic dermatophytosis, recalcitrantia. Actually, you have already, Dr. Saple, introduced it very nicely. Treatment failure when we do not get any response even after the conventional 1 month of stopping the therapy, developing continuously. That is a treatment failure. Recurrence is arbitrarily within 6 weeks if it is recurred, then it is called recurrent, and relapse it is if it is again it is arbitrarily more than 6 weeks. It was published in Ectoderm, it was published in BMC Dermatology, it was published in Indian Dermatology Online Journal. So I'm quoting from the journals. And chronic dermatophytosis, it is who suffered from more than 6 months to 1 year duration. Actually, we what we see is recalcitrant, and that is a generic term. We refer to relapse, recurrence, reinfection, persistence, and that will be the main focus of our discussion for the next half an hour, 1 hour. So we all encounter this patient again and again in our country. Kazmi Saf, if I can ask you, TB infection was simple to treat just a decade back. What has really changed? You have just like raised the issue of topical steroid to various presentation of dermatophyte. What exactly has changed?
Basically, what I feel is that when you see the patients, when they come with you with dermatophytosis, they have already had used the topical application for a longer period of time, let's say about 4 to 6 weeks, when they land into your clinic. And
Mhm.
ultimately, when you ask them that, did you visit a dermatologist? Did you visit a specialist? So their answer is no. We have gone to someone living practicing in the next street, and maybe he's a quack, and we thought, some
That is
people
the problem.
say that we think that betnovate was lying in
Yeah.
my home, so I started using betnovate. So betnovate is a drug which has been used since years and years, and people still
Will
are
not take any will not take any brand name,
all
but
right.
anyway, we all face this situation. So
Yeah,
this
yeah,
is, as per your opinion, this is the real reason.
yeah, yeah, yeah.
Yesterday Anil was also interestingly like jokingly telling something. Anil, what is your experience like when the patient coming to you and you are giving something, they're not getting the relief, and they're again applying the same drug? You just share your experience.
Yeah. My experience is, suppose, especially in case of the patient who has been using a steroid, they
Yeah,
come to us and we try to give them the ideal treatment. And
yeah,
most of the time, and 4 to 5 days after, they switch over to the back to the steroid again, because they compare our drugs efficacy in their own. They try to experience the clinical result, and they think that the steroid was better than these drugs. They think that I went to a very senior doctor expecting that my problem will be solved, but that small tube was better than all these ranges of the oral and topical medications. months. So
It's a
this
very
is really
difficult condition.
happening in many
Really.
cases, and this they confess that. And after that, we have to convince so many times, and time and again, what we have to do sometimes is, if it is tinea incognito, we have to give a, I use a word called as a counterbalance. So some, for initially in those cases we are highly inflamed and tinea incognito, I try to give the mild steroid under coverage of oral and ideal treatment of topical one along with that for few days, and then I stop that and I ask them to use the real one, so that they don't run away, not from me, from the real treatment that they require to.
Thank you. And Dr. Safle, sir, I'll just reframe the
Yes,
question for you.
yes, yes, yes.
Other than this steroid, what Dr. Kazmi has very nicely told, and Anil also
Mm,
told,
mm.
if we just keep aside the steroid problem, what
Yes, correct.
are the other problem that you see? You have a vast experience of practicing for so many years, so many decades, and teaching. So, what has really changed? Why the sudden like a up swinging of the curve? That's
Yes,
sufficient.
I think changing, you mean a changing clinical picture, correct?
Why?
Shailendra, can I have right? But apart from recurrence and the relapse, many
Yeah.
patients are coming for the extensive lesions, almost
Uh-huh.
three-fourths of the,
No, my
almost
question
more
is
than
why this
one-fourth
is
of
happening. If it is, if we keep the steroid out, so my
yeah,
question is why this is happening. I'm just asking why exactly this is happening.
yeah, okay, yeah. So, yeah, there are many reasons.
Huh,
One of the things I was just thinking why this is happening, as you said, whether the
huh.
change in the species or
Mm-hmm,
change in the virulence.
mm-hmm,
So there is one of the work, this slide shows, done by Dr. Madhu from Chennai, Dr.
mm-hmm,
Anupama from Hyderabad, and
mm-hmm,
Dr. Miskin from Mumbai, with the help of gene sequencing. What they were thinking, Trichophyton robishaki, which
mm-hmm.
was new species, but they found is not a new species, but is a subspecies of Trichophyton rubrum. Similarly, Trichophyton intelligilis is not a new species, but is a subspecies of Trichophyton metagrophyte. So, with the help of the gene sequencing, now they said there is hardly any new species. Even there is studies from Ananta Kurana from Delhi
Mm-hmm.
that there is change in the genome, but there is no change in the species. So there is no change in the species, then why this is happening? Where
So that
this
is a very very important insight you are dealing with. And if we like are you continuing with this, or I'll again come back to you sometime
you
later,
can
sir.
come back at least one
Okay,
day.
okay,
Yeah,
okay, sir.
yeah,
And so I'm just sharing my screen again. Uh, mm, is there any change in the spaces that you have already answered very nicely? And the recent change is now seen in almost equal proportion in the winter also. And my friend from Srinagar, they are telling, even in Kashmir, they are seeing during winter, they are seeing tinea that was never thought of. Recently, witnessing spot of cases of tinea facie pseudoimbricata and increasingly difficult to treat dermatophytosis. We know about the rise and fall of tinea rubrum to mentagrophyte trachophytum. You mentioned about that, and Sham Verma and Madhu published in our journal the Great Indian Epidemic of Superficial Dermatophytosis, and then they told that epidemiological transformation is a real thing, and the trachophyton rubrum to the most common is now much less. And in this study, the mentagrophyte has emerged. The decline as occurrence of the downy form of Trichophyton rubrum has also been observed, and the new beast, like it's a rapid growth of the primary culture within 5 to 7 days. It is absolutely behaving like a peculiar beast. And Anil will be interested to know that you are dealing with the familial dermatophytosis, how to prevent. Trichophyton rubrum survive for less than 12 weeks and on towel, and while Trichophyton mentagrophyte survive for more than 25 weeks on towels. So that could be the one of the reasons. And in our countries, they share the same clothes, they share the same towels. So it's almost a super bug, and we are dealing with And definitely, these are not corona, these are tinea, what we encounter. And now, as per the recent report, 93.2% are superficial dermatophytosis are actually mentagrophyte, the chronic dermatophytosis, widespread, inflammatory, resilient to treatment. So my next question, whether the causes of the astronomical upsurge of the fungal infection, host, agent, and environmental. Agent, we have discussed. So if I come back to Dr. Kaveh Chaudhary, sir, host and environment, do we want to add anything?
Yeah, exactly. Environment is very, very important. I want one point. Recently, this global warming, there is some journal they published, and very interesting to know. In insecticide, they are using azoles antifungal in insecticide in the plantations. So that
Right.
azoles producing very resistant fungus, and which is in the environment now, and people are infected already resistant organism and
Very
not
important point.
working in the. It's very,
Very
very
important point.
to know about and another research shows there now no geophilic, and also this environment is more, and also is anthropophilic becoming more 70% than the
Yes.
geophilic or from the geophilic animal. And I think this we should add another thing in here. The family contact is
Yes.
very, very important. I
Yeah.
have seen
Yeah.
one, and it is Professor Saples are already told it is
Mhm.
even rich and no rich and poor.
Yes.
One of
Yes.
the very topmost officer in the, and he is a discipline working, and he was challenging me. Nobody in the family he has got this tinea curis. And after 1 month, his son who lives in Australia, he came home and he came to the same infection.
So ask
And
the
even
using the
people,
same
yeah,
tube or
and
not.
education. Surface are also informed that
Yeah.
we must educate and counsel the patient. Counseling is a very important point to
So I'll come to you
convince our
again.
patient.
Yeah, yeah.
Yeah,
Dr. Kazmi, sir, if I
yeah.
ask you, do you think that in last 20 years, all our subcontinent, we have seen the change from the lean and thin patient to hefty patient with a metabolic syndrome? The host factor has also changed. The obesity, the so many comorbidities. What is your opinion, sir, in this?
I personally agree. I feel that what is happening around is that people who are sharing their towels, the people who are having comorbid conditions, the person, those patients, and especially in young adults and who are sportsmen in our country, who are ultimately the ones who are working in those environment and conditions where they do not have the facility of an air condition, they do not have the facility of having proper ventilation. They are the ones who are carrying these dermatophytes upon them, and they are the ones which are ultimately giving this problem to the other people. While shaking
I
hand,
understand, sir.
they are using
Yeah.
the in the when you go to the washroom, one
Hmm.
bathroom slipper or
Hmm.
one the shoes there, they are being used by the whole family. And if you have
Right.
tinea pedis, they will develop the same problem. So I personally
Right.
feel that we have to educate the patients that
Hmm.
by sharing your
Hmm.
clothes, by sharing your shoes, it would not that the love would grow among the family. It was
Hmm.
only the diseases which would grow in the family. So
Thank you,
they
sir.
have
Thank
to
you.
avoid,
Thank you.
and
Yeah.
especially one thing in the end I would like to mention regarding this question, that young children who have
Hmm.
tinea capitis
Hmm.
or who have kirion, they in the family, they generally use the same comb or the
Yes.
same towel in all the children. They are
Hmm.
being shared by the same
Hmm.
comb. The mother is using the father, the children, and this is how it is so widespread tinea capitis in our part of the world when we see among in young
And
children.
most of the time, we don't ask them about this combing, like their
Yeah,
habit,
Mhm.
yeah,
about the sharing towel. We don't ask them. So these are the things that our new generation dermatologists they should be aware about these things. Sir, very quick questions. Now, I'll not ask an elaborate question. How what, do you at all do the fungal culture? Anil, in your practice, you are a
No,
very busy
I think
practitioner.
Kaushik, I'll
Yeah.
just the
Yeah, sir.
what was important is the host factor, the immunity.
Yeah.
The immunity, according to American dermatology, that now we are dealing with the T cell, the delayed type of immunity, not the humoral immunity. That,
Yeah.
Okay, go ahead. Yeah.
Thank you. So I'll just ask, in your busy practice, we all are clinicians, other than our academic past and all that. So do you really, what percentage of cases of dermatophytosis do you send for fungal culture? Anil, do you at all do that?
Very, very, very infrequently, because
Other than
wherever
your,
academically required
yeah.
only.
And Dr. Saple, sir?
Yeah,
You are-
same thing. I agree with him. I agree with Anil.
Yeah. And any changes from Dr.
Yeah.
Chaudhary or Dr. Kazvi?
Yeah, but I do routinely now the culture of fungus, and I
For
found
superficial
90% of
dermatophytosis
the
or onychomycosis? For what?
no, for onychomycosis, for dermatophytosis,
Okay.
every
So you,
cases I do,
okay.
and mostly more than 90% cases are the metagophyte is going more.
Okay. So
Metagophyte
Dr.
because
Kazvi,
previously the rubrum is more in literature says, but in my practice, metagophyte is more than 90%. I'm routinely I do this culture in both onychomycosis.
Yeah, I personally feel that whenever we try to evaluate a patient of fungal infection, which is very chronic, the relapse is there. So generally we get the fungal culture done in those patients. But the people,
otherwise, in daily
when we,
practice, do you do much of fungal culture?
no, in our
No,
daily
that is
practice, we do not, we are not virtually asking every patient of dermatophytosis
no
for a
need
fungal
also.
culture.
Yeah.
Yeah.
So
Because why I do this culture, just 1 second, Dr. Kaushik,
yes.
because 15 days I take for the patient, give some medication, there is monotherapy, and wait for 2 weeks. By this time culture comes, and I can observe the patient after treatment, also have the result of the culture. Yeah. That's
So
I practice in my routine.
we all know about this answers that have fungal developed resistance against antifungal. That was a very, very debatable topic in recent times. To observe an increase in incidence of in vitro. We are not dealing with in vitro drug resistance in general, but what we are actually seeing is actually recalcitrant tinea, and this change is in extensive, widespread, gigantic lesion, unusual distribution, highly infectious, virulent, lacking classical central clearing to Leucemia imbricata, whole family is infected, and recalcitrant to therapy. We are seeing this photos from everywhere. I'm getting many questions from our friends from all the countries. So, what are the challenges in the treatment, sir? If I come to Dr. Saple.
Yeah, this is a very good questions, and where I'm working for last 3 years with my background of the HIV, there is something called clinical failure. The term we are using since 92, 93, because we used to get esophageal.
So before you start, I'll just tell one of our colleague, Dr. Ashish Pimple from Nagpur, just asked the same thing. Is there any light at the end of the tunnel? I mean, what is the future of dermatophytosis? Will it always be a chronic condition? That is what I wanted to know from you.
No, that's why coming first, I would like to clear it, make it clear.
Yes, sir.
That everybody was talking about resistance. So I started working, and with the background of the HIV, the clinical failure is very common. So I said, is it a clinical failure? And then I used to ask everybody, when patient comes to your clinic, you start any antifungal with the grisopulvin, turbina, patient start responding. When the patient start responding means it's a clinical failure. It cannot be resistance. Because once you name it resistance, you increase any amount of concentration, the patient is not going to respond. So most of the patient coming to our clinic, they are of a clinical failure rather than resistance. It has been, I think, yeah. So that is the first point. Yeah. What is the second question?
No, actually, what are the challenges in the treatment you face?
Yeah, the challenges, according to the main challenge, is the adherence, compliance, and the counseling. Because I have done one study, clinical observation study, almost 40% of the patients who have taken multiple antifungal drug in the past, they have been labeled as a resistant cases. The same cases we started, but with good adherence, counseling, and giving itraconazole 100 milligram BID for 6 to 8 weeks, along with the ibuprofen local application and For our surprise, we followed for 1 year. 84% of the patient, there was no relapse, no recurrence. Only 16% they had a delayed response. The problem was with the adherence, or they were on.
Completely agree, sir. There is a very recently a big study was going on in the National Medical College, Kolkata, with a large population here from the eastern part of India, and they also found similar. Like the patients who are actually they had two hands. Like one, they have like a council that did the basic things. Anil will be happy to take up this. That how to prevent, how to maintain hygiene, how not to share towels, and how to prevent all your family members. And another one, they just prescribe the medicine. And then they saw, and with the patient group where the dermatologist spent some time in explaining the situation and educating them, they have responded wonderfully. Anil, what is your opinion?
Yeah, Kausik, I was waiting to answer this question. In fact, first of all, I agree with Professor Saple that most of the cases clinically, when we deal, they say that it was okay for a few days or few months and it reoccurred again. So we cannot say that drug resistance usually that has been told. Or now one very important question rises is that, okay, we have done a lot of research, we have found the strain, we have many alternative treatment and all that. With all this, how much we can be confidently, we can say that, okay, after this research and after this treatment, the patient will be very happy for longer period. So this is a big question mark. So what I feel, what I do in my practice is that I have found that it is useful, though many consultants or many dermatologists, senior dermatologists, they may not agree to it, is the counseling is very, very important. Now, Professor Kazmi has rightly said about the fomites and the towels and sharing and all that. So I'm not going to repeat that, but I start with the dress, the costume fibers is very, very important. Can we just concentrate that initially when we used to use cotton dress, that was very good environmentally for all this situation, and global warming has, the world has come and all that. So one important thing is the costume, that is the cotton wear dress is very, very important. We have many ritual places where overdressing is done. This is very important to be kept in mind, number one. Number two, there are places like some examples has been given, like some monks, they use suppose the same razor, and most of them have got the tinea capitis in whole schools and all that. So we have saw that. So these are the factors that we have been to the those schools, and we have counseled them, we have oriented them, and so that they can change their lifestyle as much as possible, and as much it can be adjustable. That is one, that is rest.
Excellent,
Before,
Anil.
yeah, before I prescribe, I give them a brochure, which is even a company, I don't name the company, even in India and the SAARC countries, they have distributed that, and we have our own brochure to distribute, that we distribute to the patient, and we explain them that these things has to be taken care of, that is dress. Then in prophylaxis, part, we after the treatment, of course, we asked them to use some dusting powder to maintain the environment, especially for the tinea cruris and other tinea
So the
intertrigo cases.
upshot is actually, if we spend some time with the patient of tinea, then we can
Yeah,
break the chain. Like this, we are dealing with the COVID, and there's breaking
I,
of the chain. So we need to do the same thing for tinea as well. Professor Kazmi, you want to add anything on it, or we can
Yeah,
go ahead to the
I
next?
would just like to share my experience. I absolutely agree with Anil, and the problem what I feel is that the potpourri of drugs which are being used by a person here in our country as well as in your country, in your part of the world, because over the counter drugs, these are all present, and you do not need a
Exactly.
prescription from a dermatologist in order to go and buy these drugs.
Hmm.
So anyone can go to any pharmacy, and you can just ask them that I want
So there's a
some
huge
treatment for.
challenge.
And
So
I tell you, I have seen the salesmen at the pharmacy shops who are selling, that the person is standing next to me and he asks him, who is absolutely not aware of what fungal diseases are, that I've got a fungal, can you give me any cream? Can you give me any tube to apply? And then that salesman who does not have any knowledge what it is,
The same
or
thing
the
happens all over
pharmaceutical
the
company who,
subcontinent,
yeah,
the similar
yeah.
situation.
So this is what our challenge, I personally feel,
So
that yeah,
I think we have already dealt with all those problems. Now let us focus on the therapeutic part, because so many questions are now coming on the therapy. So what
yeah,
is the
yeah, yeah.
scope of topical antifungal in today's practice? Very, very quickly, Dr. Saple. Any scope of topical antifungal, and what is
I think,
your favorite?
yeah, with this, we tried to study, and then we found most of the topical antifungal, most of them, they're working very nicely. You
Yes.
can use any whatever you want. Only they say laliconazole, ibuconazole, or cetaconazole, they are slightly better
Mhm.
according to study, but we can use any antifungal topical. That is our experience.
Dr. Chaudhary?
Yeah, because topical drug is usually it is an OTC product even in the Western world.
Mhm.
So everybody use this and very good result. But this is the main point, that they are developing the failure of treatment because they're using all these products before. And the suppressor was telling the very important, the newer products like the ibuconazole or cetaconazole are working better because these are newer drugs. Older
Mhm.
drug becoming resistance or failure of treatment.
Mhm.
And we should be very much cautious to give first one, very important diagnosis should be very proper. And at the same time, not only the topical, we should systemic together. But topical product is wonderful even for the
Topical
children,
product,
even
I
for
think,
the,
sir, in
yeah,
another scenario, if I are dealing with a patient who are actually infants or very young children,
infant and
the
elderly,
topical antifungal will be
pregnancy,
our mainstay of
pregnancy.
treatment, pregnancy. And do you use any potent topical steroid? We have discussed everything. We'll just need answer from the very senior and erudite dermatologist of this subcontinent, yes or no. Do you use potent topical steroid with antifungal, yes or no? Dr. Kazmi?
No,
No. Dr. Saple,
Yeah,
sir?
basically, no,
No,
no.
no, not at all, not at all.
So, do you think that one of the reason, we all know that this is one of the reason, if not the main reason, because of, I don't know about other countries, but in India from 2007, the DPCO, the Drug Price Control, that actually opened the Pandora's box. Now, before this, it was beclomethasone, betamethasone. Now, every combination is with clobetasol, that is the strongest steroid. And
yeah.
after it completely unlocked a barrage, a tsunami of infection, and that completely changed the scenario. And we have observed a significant number of relapse cases with itraconazole. And what are the other alternatives available in such cases? Very, very quickly, Dr. Saple.
Yeah, see, according to me, itraconazole is one of the wonderful drugs. It
That's
works
still the
very
mainstay.
well. Yeah, if you follow the compliance, it works very well. But itraconazole has got its limitation. One of the limitation is the
You know, you told the
bioavailability.
PPI and
That
all
is,
that. Yeah,
yeah,
bioavailability.
bioavailability is
It's
about
only
50%.
55%. Yeah.
Yeah, so we have to using antacid. Already I've mentioned.
Mhm.
Another problem is the dissolution. Dissolution profile has to match this British pharmacopoeia or USA pharmacopoeia. And the lastly, the capsule has to be HPMC capsule. It should not be gelatin capsule. And number, the palette has to be uniform. If you have any brand you're prescribing itraconazole, if you have all this quality, and if you use proper compliance adherence, I'm sure you don't need any other drug.
Dr. Kazmi, sir, in Pakistan also, I know there are various brands of itraconazole. But do you prefer to go ahead with the leader that who invented the itraconazole? I'm sure that is also very costly. I'm not taking the name, but what
Yeah.
is your experience? Those are the best.
Yeah, I think, Me Too's are available everywhere in the world,
Yes,
and
yes.
especially in our part of the world. But my preference is always that you go with the company, with a multinational or with any company which has introduced this drug initially,
Yes,
right?
yes,
Now, the
yes,
only
yes.
problem is you have to see the pocket of your patient. That
Hmm.
is very important, because
Hmm.
when people come, they always say that, doctor, I am a laborer. I cannot afford expensive
So
medicine.
I
So
get
you
your
give
point,
me
and
any
there is the
Me Too
problem.
medicine. Yeah, yeah,
Yeah,
yeah, yeah.
that is the problem.
So that is
So
the
Because
problem.
the itraconazole was so much publicity when it was this first introduced,
yeah,
and
yeah.
it was widely used. Maybe that is
Mhm.
one of the cause of failure now from the
Mhm.
itraconazole.
Sir, in the Western world, if you carefully observe, you are there in Canada, they use a lot of terbinafine, and we are not at all
Yeah.
using terbinafine at all. Terbinafine in this whole subcontinent is completely now failed, and we all know that. We all agree about that. But in Western world, they don't believe that terbinafine is not working. Somehow, it's a two different world together, and I
Because
don't think.
Lamisil get a very big market here,
Yes,
and all
yes.
the people they are very much fond of terbinafine here,
So
and even butyrenafine. Yeah.
from
I
our
think
panel, very senior four
Kaushik, can I
dermatologists.
add here?
Yes,
Kaushik,
sir.
can I
Yes,
add?
sir. Yes, yes. Go
Yeah,
ahead, please.
so as Kabir has said, that this terbinafine, we were also under same impression it doesn't work. But when we did a counseling, increase the adherence and the compliance,
I know that. Yes.
it works. The problem with our is we are not doing proper counseling.
Mhm. Yes. Yes.
Yeah.
It's getting dropped, his voice.
Okay.
Actually, I think from this forum, this very senior dermatologist, for erudite clinician, the message should be loud and clear, because many part of our subcontinent, there is a tendency, even among dermatologists, of using. Can you hear me properly?
Yeah.
Yeah.
Please.
Using multiple drugs like itraconazole and terbinafine together in the same prescription. So I don't think we should waste time on this slide. That should be strictly avoided, because that's not ethical at all. And I'm not wasting time on our tinea with modified with steroid, and because we have so many things, and we already have evidence that how exactly topical steroid changes the virulence and all these things of a fungal infection. So I'm not wasting time on that, but I'll go to a few more questions before we sum it up. So these are all things we every day we encounter in our part of the globe. Horrific condition, definitely. When even we were students, we never used to get this kind of a condition in front of us. This we lost this child last year. He was using one tube of clobetasol per day on his body. I don't know why. And this kind of scenario, again. So this so systemic disease with fungal infection, metabolic syndrome related. Do you think that any metabolic syndrome is associated with this fungal infections?
Yes, because obesity is a very big problem with fungal infection, and metabolic syndrome is here is an important factor, plays role in of resistant fungal infection, definitely.
Okay, and Dr. Safle, sir?
Yeah, see, almost in India, the every sixth person is suffering from diabetes. That is about the diabetes. So any patient comes with a metabolic syndrome, there is a dyslipidemia with the other comorbidity, that is renal problem, liver problem, kidney problem, malignancy, because now people are living for long. So we are dealing with a lot of comorbidity along with the metabolic problem. So we have to be very careful while using these drugs.
So what is the commonest underlying disease? If a patient of fungal infection comes to you, Anil, what do you think the commonest underlying disease may be? We know about the obesity and all these things.
Yeah, obesity is just environmental is one, but otherwise, if you talk about metabolic type, the common here in our part is the diabetes only.
Mhm. But actually, as per the conventional belief, candidiasis is there with diabetes. But there is no real evidence that diabetes and dermatophytosis. Maybe we need to generate more evidence for this, but we regularly say this. And Dr. Sapler will love to know, like answer this, but actually we all know that how significant the drug interaction of itraconazole with oral antidiabetic and PPI. It is anyone can take this
Yeah,
question.
yeah.
This
Shall
is
I?
one of the reason why it fails.
See, when you are talking about any drugs, we got to know pharmacokinetic, and one of the pharmacokinetic is the metabolism. When coming to the metabolism, itraconazole is metabolized in the liver with the CIP 450. So the itraconazole has. Can you hear me?
Yes, sir. Perfect.
Yeah.
So itraconazole being the metabolized in the liver with the CYP 450, it has got lot of drug-drug interaction, and that's why the itraconazole got lot limitation. Then compared to terbinafine is a very good drug. There's hardly, except when you're using the psychiatric drugs, terbinafine cannot be used. And the next drug is fluconazole, what I am using for last 2 years continuously. Somehow people are under impression when you use fluconazole, it is also azole. So it is also have got same drug-drug interaction like itraconazole, but it is not so, because fluconazole has been metabolized by what is called CYP29C, and it has got only hardly significance about the metabolism in the liver. It is 80 to 85% excreted in the renal. So fluconazole has got hardly any drug-drug interaction. Grisophulvin, it has, but grisophulvin can be used with the anti-diabetic
So
drugs.
we actually forget
Terbinafine
this
can be
older
used with.
molecules should not. What should be a characteristic of ideal oral antifungal, and which oral antifungal you suggest close to ideal? I'll not come to this because it's a too vague a question. I'm getting too many questions from Bangladesh, Nepal, and all. A very interesting question from our Bangladesh colleague, Lieutenant Colonel Mahbub Kamal from Dhaka. So it's not indicated. It has been seen many of our colleagues they use voriconazole for superficial dermatophytosis. And do you advocate this voriconazole BD and dual systemic
Let me answer
antifungal drugs
this
for
question,
dermatophytosis?
Dr. Lahiri.
Yes.
Voriconazole is given the FDA approval only for the oropharyngeal candidiasis
That is the problem.
and
Yes.
aspergillosis. Aspergillosis, it became a very deadly fungus, and they given only for use in case of these two conditions.
I
And
wanted
also
to
World
know
Health,
this from you.
World Health declared it as an essential drug for aspergillosis, but not for the cutaneous fungus. But
Yeah.
because people are nowhere in our country, a lot of people are using this drug even in the beginning.
Yeah,
He is very right,
Dr. Kazmi,
and it should not be used.
Yeah.
Dr. Kazmi, I think your opinion should be the similar.
Yeah,
We
I
should
think
not waste
I
this.
agree with what Kabir is saying. I would just like to mention one thing. When we were discussing itraconazole, and Dr. Saple has absolutely brilliantly narrated whatever is the role of it. In our country, itraconazole, generally people feel that candida, whenever it is there, itraconazole is the best only for candida. And our favorite antifungal here in my country is terbinafine. So
Okay.
people still go for terbinafine, and itraconazole is there. But I agree with Kabir Chaudhary that his experience is the same as what we see in Pakistan.
Anil, you want to add anything on it?
No, I agree with Professor Kazmi and Professor Kabir in
Okay.
this regard.
Thank you.
I think
These
Kaushik, I
are
would
the
like
basic.
to add. Kaushik, I
Yes,
would
sir.
like to add.
Yes, sir.
I entirely agree with them. Voriconazole should not be used. There are many reasons. One of the reasons, voriconazole concentration serum is very high, but stratum corneum is very less. Number two, there are hardly any trials. One of the trial, but that is in vitro. Number three, we have to preserve, as all of us said, for our life saving for a systemic drug. And the
Exactly.
lastly, it requires therapeutic monitoring to use
Very nicely
voriconazole.
pointed out, sir. And I
Professor
thank Lieutenant Colonel
Saples
Mahbub Kamal for
is very
asking this question
important,
from Dhaka.
very important point. The
Ah.
atom bomb must be kept reserved for the future.
Yes,
Exactly.
correct.
Voriconazole
Yes,
should be
right.
kept.
And I
Yeah,
must thank
absolutely right.
I
Absolutely
must
right.
thank Lieutenant Colonel Mahbub Kamal from Dhaka for asking this question. So, what is your choice of systemic antifungal in children? If I start from Professor Kazmi sir, below 6 years and below 12 years.
Basically, whenever children come to me, it all depends that which dermatophytosis, morphological, which type of dermatophytosis are they suffering from. And my first option is always that we should start with topical antifungals.
Mhm.
I would not like to put these children below 6, especially below 6, in oral antifungals.
Below
So
12?
I generally start with topical antifungals, and after giving topical antifungals, I generally see that children below 6 years of age, they do not require any oral antifungal, and the disease is gone. But when you talk of below 12 years of age, then we do give antifungals, and I think that in that age group, terbinafine is very effective. What I have seen, oral terbinafine and then topical and with a mixture of topical antifungal, we do get very good results.
Thank you, sir. And Dr. Chaudhary, Kabir
Yeah,
Chaudhary.
below 6 years, usually use the topical application is very, very good, and no need to go for
Below
the
12
systemic.
years?
And in the below 6 years, and yes, below 12 years, and if the number of the lesion is less, we use topical. If the number of lesions is more than 2 or 3, then we go for the systemic. Also, and fluconazole
What
I use
systemic you
more.
use? What systemic you use?
Fluconazole, fluconazole use I
Fluconazole.
more.
And
I
Anil,
think, Kaushik, I would
yes,
like to add here.
yes, sir.
No, if you go for a scientific study, the best drug in the lactating mother, infant, children
I'm
is
coming to lactating
fluconazole.
bit later,
Yeah,
but
it's a
for
drug
Yeah.
of
this,
Children.
choice is the fluconazole. Of course, terbinafine is also very
so I just
safe.
wanted one line answer. You want fluconazole and also
Yeah,
terbinafine. And children, pregnancy, geriatrics, and liver kidney compromised patient, just one by one. So in children, we already know that fluconazole you prefer, though there are some evidence with itraconazole also, definitely with terbinafine. And pregnancy, terbinafine is B, category B. Others are not
big.
actually allowed. And geriatrics, you sir, Dr. Saple,
Yeah, geriatrics, of course, there are
the patient with
multi-pharmacy, there
kidney
is a many drugs.
compromisation.
Drug of choice is a less drug interaction, that is fluconazole or terbinafine. But as the cost is a main problem, I prefer fluconazole.
Okay, sir. So oral antifungal agent for common fungal infection. This is from the Clinical Dermatological Review 2017. These are the drugs that has been recommended as per the standard protocol: bisulfalbin, itraconazole, terbinafine, and fluconazole. What our erudite panelists have told, we all know about the dosage schedule. So these are the things which are actually recommended. And in the pediatric age group, the treatment of cutaneous tinea is generally limited to the topical antifungal. Everybody agreed to that. A rapid turnover of the skin may be contributing to relatively better clinical response. So do not just make the anxious couple sitting in front of you a little assured that it will be absolutely okay with the topicals only. If not, the clinical experience with oral griseofulvin terbinafine used in children has been the setting, the tinea capitis and onychomycosis, and these agents may be used in extensive refractory cutaneous tinea as per the standard literature and the evidence. And several studies of usage of terbinafine use of children. And you know, the itraconazole also used to 5 milligram per kg of body weight. And in pregnancy, and this is a big question by many of our colleagues from all over Bangladesh, Nepal, and also India, Pakistan. And this is actually the list internationally. You can take a screenshot also, antifungal, the risks and the benefits. And among these, all are actually pregnancy category D or C.
C, mostly C.
Yeah, but terbinafine is actually category B medicine that is there from the international
Yes, yes.
guidelines. Can we combine two antifungal if it is required, or one is enough? Dr. Kazmi?
Yeah, I personally feel that if it is a resistant type of fungal infection, and the patient has already taken many antifungal before, and we feel that there is some form of eczema or erythema there along with the fungal infection, we should combine it.
Judiciously, as a senior person, you combine sometimes.
Yeah, yeah,
So
yeah.
of other panelists, there is no need to agree with whatever others say. Anil, Do you agree what Dr. Kazmi told, or you also use two antifungal
No,
together?
no, I do not combine.
Yeah.
When there's a question of combo treatment, I try to do a combo treatment with the oral and topical one rather than two
Okay.
oral one.
So that is how our this subcontinent is divergent and beautiful together.
Yeah,
And
I agree with Anil. And no steroid, I don't use. No.
yes, so
Better to use petroleum
this is
jelly.
an
Petroleum jelly for the erythema is good,
Mhm.
other than the steroid.
I think Kaushik, I would like to
Yes, sir.
add here.
Yes, sir. Yes, sir.
Yeah, when you use a combination of multiple antifungal, first you have to think of pill burden, how many tablets you can give. Secondly, the toxicity, because most of the antifungal, they got very high concentration in stratum corneum. Thirdly, is drug-drug interaction. Fourthly, the cost. And lastly, important is the adherence and the compliance. So by using multiple combination, which is first thing not necessary, if you use it, you are facing all this music. So I didn't think we should not use at all.
Thank you, sir. Thank you very much. And there are some question from Nepal. Dr. Sabhyata, she is asking, is polyester harmful in tinea infection? I have seen like 1,000 patients have dermatophytosis polyester clothes, so they react. So what is your opinion, Dr. Anil Jha? You can tell.
Well, I did not get the question. May I?
Polyester from
Maybe
polyester
Synthetic
clothes.
clothes.
Synthetic clothes, are this harmful, and they invite the tinea infection and all that? So what is
I think I have answered the
yes,
question
Already
that's
he
why
told.
I asked
regarding
you.
the
Yeah,
fibers of the dress, which is very
exactly.
important. They do not observe the sweats, the
Mhm,
perspiration, and that is one of the humid condition can lead to
mhm,
the recurrent dermatophytosis.
mhm.
Yeah, he's right.
Okay, okay, sir.
I agree with Anil that I
Mhm.
think what he has mentioned experience, it's absolutely correct.
So if we
Yeah,
come
he's
back,
absolutely, yeah,
if
absolutely right. Anil is absolutely, I agree with him.
Yeah.
if we come back to another part, like another question is a person with a cardiac abnormality, deranged LFT, deranged renal function test. What Dr. Abhirami from Bhubaneswar, she is asking, what will be your drug of choice? Cardiac abnormality, deranged LFT, deranged RFT, other than the topicals.
You're
BFT
asking
may
who?
be a better choice.
Yeah. What? What will be the answer, sir?
Because the cardiac problem is other than topical, we can use terbinafine.
Yeah. Yes. Yes.
I think,
And some medicine which do not react with others, so we should avoid the modern medicines, and we can go back to some older medicine. So this is
I,
an
I
interesting
think,
slide.
so,
Level of fluconazole in serum, stratum corneum, epidermis, dermis, and fluconazole is found to be high in concentration in stratum corneum and sweat and dermis, epidermis, indicating that it might be effective not only in the treatment of dermatomycosis localized in stratum corneum, but also in the fungal infection, deeper part of dermis. And this is also a very interesting article way back in 1993, levels of fluconazole in the serum, stratum corneum,
Yeah.
and eccrine sweat. So do you, what dose and what long? I know Dr. Saple has worked on this topic, daily fluconazole. And there is a recent article published in IJD, multi-drug therapy, terbinafine plus daily fluconazole is more effective than terbinafine alone. So, Dr. Saple, your experience, and we know that it is efficacious, but is
yeah,
it safe?
uh,
Is it safe?
yeah, I think this is a very good question. But first, I would like to answer the previous questions.
Please do.
When the person come with a kidney problem, cardiac problems, fluconazole is very safe because itraconazole is not safe. In Africa, they have done the study giving 400 milligram fluconazole in 1,000 patients of HIV. They have followed the QT interval and they found it very safe and you get hardly any drug-drug interaction. So along with the terbinafine, as Kabir said, fluconazole is another safe drugs. Now coming to what is the next question you asked about the
So,
fluconazole?
fluconazole, how safe is it? So you
Yeah,
have
correct.
a wonderful experience of
Yeah,
many
yeah.
years of using
I
the
think
use
we
of
are
fluconazole.
using fluconazole. It's available as a diflucan 92 by Pfizer. We use in cryptococcal meningitis, 1200 milligram IV for 3 weeks, followed maintenance 400 milligram daily for 8 to 9 months. So we have got such a huge experience. So using 150 milligram daily for 6 to 8 weeks is very safe. I'm using for last 2 years continuously. It's very safe drug.
So we have a published article on also on this. And suppose again, if I come back to this situation, a 21-day-old infant, this is a shame for our subcontinent. This can happen only our part of the globe. And this is the first gift from her mother. And the father is also infected. And what will be your approach, Anil, if they comes to you? How will you treat the baby? How will you treat the mother? I'll come to all of you one by one. Be very, very brief because now the time is getting at the end of our schedule.
Yeah, I think for baby, I would like to prefer the topical one, and for the mother, we can give the initially
Will be
proper
lactating.
dose,
She'll
that
be
once a
lactating.
week dose of fluconazole and topical cream at the same time, so that both are balanced.
Mhm. And Dr. Kazmi sir, Dr. Kazmi sir, I think he is off. Dr. Kavit Chaudhary.
Yes, Dr. Anil is very nicely prescribed. The child we can give only topical. Mother can be given systemic fluconazole, maybe secreted in the milk. It may help for the child because of the mother's milk.
Yeah.
And
With a
here,
milder dose
Anil,
than
what
topical
you
is
also told, spend some time with the patient, tell them to
counseling.
use the hygiene. What we are doing, this is the COVID era, and also the avoidance of using the same towel. The again the ask whether they are using any local shop owners given tube and all those things. Any of the family members using any steroid. And other than this, I entirely agree with you. Dr. Sapli, you want to add anything on this? In this
No,
situation?
you absolutely said. Apart from all precautions, I think all these ages, I'll give fluconazole for infant, mother, father, and even the brother. Yeah,
Thank
because
you.
fluconazole can be given at any age.
Mhm,
Yeah.
Of course, terbinafine can be also given, but I'll prefer because of the cost.
mhm.
Cost is very important when the large number of family are staying together. The cost is very important.
So we all know about this familial dermatophytosis. It is emerging. If one family member we know about the scabies is infected, is it necessary to treat other family members with minimal antifungal dose as prophylaxis? Is there any evidence, or you just spend some time and educate them? What do you do? Anybody can take.
Actually,
Doctor,
Yeah, can
actually,
I say? Okay,
yes, sir.
please.
Yes,
lower
please.
doses,
Anil
lower
would
doses
love
we
to
should.
answer.
Okay.
Yeah, in this condition, apart from the counseling, I think topical antifungals should be given as in prophylaxis for especially for the intertriginous area as in prophylaxis to start with.
Mhm.
And in counseling, it has to be asked to be vigilant for searching the body part where whenever it starts, of course, it has to be then proper treatment can be given. But I think prophylaxis treatment, the then along with that, the prophylaxis, like I have said, like the powder form, the dress, all this has to be taken care of along with that.
Thank you, Anil. Thank you. Very nice
Yeah.
inputs. So we are coming to the end of our session, and the take-home messages will be very brief. Nothing. Early diagnosis of superficial fungal infection and proper treatment is needed. Strong steroid cream should not be used with antifungal, and selection of proper systemic antifungal is necessary. Try to pick up any underlying clinical comorbidity. So these are the reference from which we all like discussed, and all the discussion were based on evidence, hard evidence. And this is my book, was published last year on this thing. At the end of the world, only two things will remain. One is cockroach, and one is
Yeah.
Chenia. And we all know about the diamonds are forever, but I think now the situation is it is the fungi are also forever. And so this is also another slide. And in this era of unfortunate clinical this social distancing, our creatures have also learned this, but I'm sure again this subcontinent and the whole world will come together like this. And thank you very much for your kind attention, and thank you very much FDC for making this history a real thing for all of us. It was very pleasant to exchange views with the foremost erudite academician, very senior dermatologist of our subcontinent. Thank you very much.
Thank you very much. Thank you,
I
Kaushik,
think,
Professor
yeah, I
Sapli.
think, yeah, Shailendra, can you
Yes,
show
sir.
that slide? There is one request before we end. There is a request that the Bombay is bidding for Dermacon International 2023.
All the
So I
best.
request on behalf of our committee, please vote for Mumbai Dermacon 2023.
Yeah.
And first, I must congratulate Kaushik. He has done wonderful job.
Yeah,
And of course, all
I agree.
panelists for their
Yeah.
inputs. All panel,
Yeah.
yes. Yeah. So
Thank you, everybody. Thank you, FDC and
Also,
everyone.
thank you again,
for
Dr. Kaushik.
including
Thank
me
you,
in
everybody.
this
Yeah.
August discussion. Yeah.
okay, bye bye.
Thank you.
Bye bye.
Thank you, sir.
Dr. Kaushik, being you are you are a very
everybody.
very young and promising for the whole world era. What about the laser treatment in fungus that is left? We can discuss it later on.
Yeah.
Because FDA already approved this
That is for
laser for fungal treatment.
onychomycosis, whether
Oh,
laser
yeah.
is treated or the heat is generated,
Yeah.
and that kills the fungus. So that is, the jury is still out. But anyway, FDC has already approved. FDA has already approved. About
Yeah,
it.
FDA, yeah.
Thank you, Professor Sapli.
Yes.
Thank you,
Panelist.
Professor
Thank you, sir.
Sapli,
Yeah,
Dr.
calling us
Sapli
very young. Though we are not very young now, but thank you for calling us very. Myself and Kaushik, we are from the same generation.
Yes,
Thank you
yes,
for
yes.
calling us very young.
Yeah.
Thank you.
Yeah.
Okay.
Thank
Okay.
Thank you, thank you,
Yeah,
thank you,
thank you.
sir. It
Yeah,
was a
yeah.
wonderful,
Bye-bye.
wonderful session, sir.
Bye-bye.
And I
Yeah.
would like to thank Dr. Kaushik Larry for excellent moderation of the session. And thank you for all the panel members also, Professor Dr. Kabir Chaudhary, Professor Dr. DG Saple, Professor Dr. Atif Kazmi, and Professor Dr. Anil Kumar Jha for your taking us through this enriching session and sharing your knowledge, sir. I'm sure all the audience present here would have got many practical points to improve upon and successfully manage dermatophytosis in their practice. And lastly, I would like to thank all the doctors who took time from their busy schedule and attend this webinar. Thank you so much, everyone. Thank you.
Thank you. Thank you so much. Thank you.
Thank you, bye.
Yeah, stay safe, take care. Yeah, okay.
Thank you, everybody. Stay.
Bye. Yeah.
Sailendra,
Yes, sir.
do you know how many participants attended this webinar?
Yes, sir. I'll just